Thank you so much for that presentation. I think I'm going to invite Symma and Brian to have a seat here at the table. We've got probably about 15 minutes for questions, and Jacob and Boris are circulating with microphones. So I think I'm going to invoke moderator's privilege, actually, and I'm going to pose a question first to Symma. I was interested in how you were trying to disaggregate the CBPR portfolio into outreach and engagement elements, and because the theme of this conference is about transdisciplinary partnerships across the sciences and communities, I wanted to ask if you could characterize the teams that you see working in those two different kinds of CBPR projects, and just say a little bit about how you see where the disciplinary barriers are and where the opportunities are for community engagement.
Well, as you saw from the timeline that both Gwen and I showed, many of these programs began a long time ago when academia was still central in research, and community-based participatory research still treated those in the community as participating in the academic endeavor. Those programs are ongoing, and many of them have community outreach cores. They're actually called that. And their main initial charge, though some of them have definitely evolved, was to translate the findings, provide information about the science or about the health risks to people in the community. Newer programs and those outreach cores that have evolved are now more interactive. They depend more on input from community members. They, as the Research to Action program I talked about alluded to, we now have this higher expectation that community members and those affected by health risk issues will help identify the research question. They'll help develop the proposal. They'll help recruit participants. Importantly, they will help translate the findings. And in some cases, in the BSERP program, we've had translations into Vietnamese and Spanish. We adapted the materials for rural communities who had lower health literacy than some of the urban organizations that were involved in the program. I don't know if that answered your question.
That's great, thank you. Other questions from the audience? At the back.
Hi, I'm just wondering if any of the panelists could speak to how you are incorporating or addressing structural racism as a factor or contributor to community pollution and community health effects?
In our case, where we're working what we call the Eastern Gulf Coast, from eastern Alabama down through Florida, there are very few pockets of minorities, actually. It's fairly homogenous, and that's one of the reasons why we included the Pensacola field site, because of the large population of African Americans there, and particularly the role of subsistence fishing that might place them at a higher level of risk from some types of contaminants from the oil spill. So there we worked specific with that organization, Citizens Against Toxic Exposure, to recruit African Americans. We held focus groups as to try and identify if there were particular risks that needed to be addressed in what we were doing. We found that there actually weren't a lot of specific risks to that population that we didn't anticipate across the region. In other areas, there's much greater ethnic diversity, including pockets of Vietnamese fishers nearby our field site, and then the great ethnic and racial diversity that's in Louisiana. So maybe you want to speak more to that.
So one part of the answer to you is that that's what I was referring to when I talked about raising awareness about the need to more fully incorporate social determinants of health. I see environmental health disparities definitely are occurring in lower socioeconomic situations. It's definitely linked to racism. A particular focus over the last 2 years for me has been working with tribal communities where racism is definitely a factor. Another way that I, as a program officer, deal with that is to partner very closely with colleagues in the National Institute of Minority Health and Health Disparities on programs, and with people in other institutes with a great interest in tribal activities, because together we can address it more fully. It's not central to the NIH mission, but it is a component of it. But if I partner with the Institute of Minority Health and Health Disparities, where that is a greater interest, and bring in the environmental element into their programs, then together we're addressing it with a greater expertise and a greater funding power by combining our institute interests. Did I answer that question?
Other questions? Susanna.
Is it on? Yeah, there we go. Hi, I'm Jonathan London from UC Davis, and we've developed a few community outreach and engagement cores for some of the projects that you're speaking about, the directorates. And I'm wondering if there's some promising practices that you've heard about of how to institutionalize these kinds of efforts, so it's not a proposal by proposal type effort, but something that has this kind of sustainability and staying power over the years, which seems really important for community engagement as well, to be able to sustain those relationships and not be dependent on 4 or 5 year funding cycles.
One important way is to raise the health literacy and environmental health literacy of members of the community. Another way is to encourage research that provides cost-effective and sustainable solutions to community rather than highly technical ones that depend on the project funding period to fund. But Phil mentioned earlier the PEPH network, and by joining that listserv, one of the things is there's a depository of resources. There's a lot of active interaction between the people who belong to this PEPH network about best practices, and the meetings that are held is an opportunity to find out what is more sustainable. I don't have the time now, and we're all hungry to go into particular practices, but we could talk more about it if you'd like.
Other questions? Mathieu.
Thanks. It's more a comment than a question. I'm a French Canadian, so I do sociology in the health domain in Canada. I'm extremely surprised and pleased to see how the social scientists are apparently well represented into the NIH. It's in Canada in 2000, the federal government has shut down the previous funding agency and has developed what we call it's the CIHR, Canadian Institute for Health Research. And the kind of conversation that we're having today here about social science in the health domain, it's absolutely impossible in Canada now. There has been so many papers by social scientists saying that the federal government in Canada is killing social science in the health domain. So, can you come to Canada? So that was my comment.
I'd actually like to respond to that, and I didn't give background, but I have worked with scientists since 1984. It was never my intention as a social scientist to work with other social scientists. I think one way to achieve this type of collaboration is for social scientists to learn how to navigate the domain of science. And then once on the inside, you have more of an effect. So I think that's one way to go. Canada is too cold, sorry.
Mathieu, do you want to follow up on that? Because I know you've got some research findings that complicate that question a little bit.
Yeah, okay. I have so much to say, so much, because I've been studying this for the last 10 years in Canada. And I did sit on some CIHR peer review committee. We did wrote like tons of letter to the council at CIHR, and currently it's impossible to do what you're. This is what we're trying to do, but it's not possible at the current time because the clinical epidemiologists now are truly empowered in the health domain in Canada, and there's no way, like, I've been reviewing the council for the last 15 years, the discipline that they are affiliated with, and like, you have like 90% of the people who make decisions at the CIHR who have an MD degree or an MD PhD degree in biomedical science, and you have like 1% of social scientists. So, and I've been one of them. And it's impossible to be heard. Yeah. So just like I'm complaining again, sorry.
Well, but let me point out
to be yourself.
that 400 is Gwen here. Gwen, how many people at NIH?
NIH?
Yeah,
10,000.
20,000. So 400 might be 1% as well. And the majority of them were behavioral scientists. So we're a tiny minority. Don't misunderstand that 400.
But I will get in touch with you to know more about
Certainly.
NIH. Yeah.
Certainly.
Thank you.
Phil is giving me the hairy eyeball here that we need to kind of wrap things up. But I want to thank our panelists very much for our discussion.